Welcome to everyone who's here and who may be watching this later to this year's first Anne Klibanski Visiting Lecture Series. My name is Shannon Scott-Vernalia. I have the privilege of directing the Office for Clinical Careers in the Center for Faculty Development. And today's session is especially important to me because we have two pediatric endocrinologists joining us. Our own Dr. Rachel Whooten will talk about understanding the natural history of polycystic ovary syndrome, insights from a prospective cohort, Project Viva, and Dr. Srinivasan, an MGH graduate from 2016, who's now at the University of California in San Francisco, will present on the genetics of type 2 diabetes in youth, where we are, and the road ahead. We like to give a brief history of the Anne Klibanski Visiting Scholar Award Program. This was created by former CFD Director Miriam Burdella to offer MGH women faculty the opportunity to serve as visiting virtual professors and give grand rounds or other special lectures at national or international institutions organized by the Scholars Champion, a senior faculty member at MGH, and the Center for Faculty Development. The program and accompanying lecture series is named after Anne Klibanski, the president and CEO of Mass General Brigham and former director of the Center for Faculty Development. A highly successful researcher, Dr. Klibanski has been a strong supporter and advocate for women throughout her career. The program began in 2020, and our original cohort of 36 scholars are shown here. In 2021 to 2022, I had the privilege of being part of the second cohort of 32 scholars. Our third cohort in 2022 to 2023 had 31 scholars, and this year, our fourth year, we have 29 new scholars, including Dr. Whooten, who'll be presenting today. This program would not be successful without the commitment and energy of all of our AK Scholars champions who are helping this year's scholars find exciting speaking engagements. The goal of the Visiting Lecture Series is to catalyze and foster collaborations across national and international institutions. And here are a few of the institutions we have collaborated with through the years. And highlighted in yellow, you can see the University of California, San Francisco. I'm here to represent Dr. Srinivasan. Now I'll get to introduce our two speakers. Dr. Rachel Whooten is an assistant professor of pediatrics at MGH, where she is a member of the Division of Pediatric Endocrinology, as well as the General Academic Pediatric Division. She graduated from Williams College and Boston University School of Medicine and completed her residency in pediatrics at UCSF, moving back to Boston to complete her fellowship in pediatric endocrinology and health services research at MGH. She has a longstanding interest in community-based strategies for healthy lifestyles, specifically relating to physical activity promotion in childcare and schools. She is currently supported by a K23 award and NIDDK addressing physical activity as a potential strategy for PCOS prevention. Dr. Srinivasan is a clinician, scientist, and assistant professor of pediatrics in the Division of Pediatric Endocrinology at the University of California, San Francisco. She obtained her medical degree from Pondicherry Institute of Medical Sciences in India and completed her pediatric residency at both SUNY Downstate Medical Center in New York and Tufts Medical Center in Boston. She then went on to do fellowship here in pediatric endocrinology at MGH and joined the UCSF faculty in 2016. Recently, she obtained a master's degree in clinical research from UCSF. Dr. Srinivasan's clinical and scientific focus is on type 2 diabetes in youth. So with all of that, I now pass the virtual microphone on to Dr. Whooten, who will get us started. Thank you, everyone.
Great. Okay. Thank you so much. And as Dr. Scott-Vernalia said, I have no disclosures, and I'm hoping to use some insights from my work with the longitudinal birth cohort to shed some light on the development of PCOS among adolescents. So we'll cover these objectives through today. So PCOS is one of the most common endocrinopathies that affect adult reproductive women, but we do know that the start of PCOS does happen prior to adolescence and does have impacts throughout the life course. PCOS is characterized by a complex etiology that we'll work on unpacking a little bit today, also with a heterogeneous clinical presentation, and then among women and adolescents with PCOS, often a delayed diagnosis and potential dissatisfaction with care. There are many comorbidities associated with PCOS, and on most recent estimates, a public health burden in excess of $15 billion in 2021 US dollars. So a clear public health priority. And notably, I want to mention that while PCOS does occur in both what we typically think a lot about, like lean and also obese women, obesity may exacerbate some of the risk that is associated with PCOS. PCOS prevalence in adult women, estimates range from about 10 to 13% of adult women, but this is really dependent on the population studied as well as the diagnostic criteria that we apply in diagnosing PCOS. There has been evolution in our understanding of PCOS over time. I always like to kind of look back to the history in terms of understanding how these conditions had been viewed previously, but kind of this quote from Hippocrates many years ago categorizes like kind of the few main components of PCOS that we think about today, which is menstrual irregularity, clinical hyperandrogenism, and then kind of as associated sequela of PCOS, potential for infertility. This was first described in our modern medical literature in 1935 and was referred to as Stein-Leventhal syndrome. And I want to mention this because a lot of what we're going to talk about today doesn't have much to do with the ovaries specifically, but really this kind of morphological appearance of the ovaries and the cysts in the ovaries, and then effects of removing the ovaries kind of really defined kind of the initial terminology in PCOS diagnosis. But over the years, our evolution of PCOS diagnostic criteria has occurred. The first official diagnosis and ICD-9 coding of PCOS happened in 1990 with the NIH criteria. And this has evolved throughout the years to some other criteria. The Rotterdam criteria you may hear talked about sometimes in relation to PCOS, the Androgen Access Society criteria. And I'm mentioning these because, as I said before, that the prevalence really depends on the diagnostic criteria applied. So the most restrictive diagnostic criteria is the NIH criteria, which requires hyperandrogenism and ovulatory dysfunction. The least restrictive is the Rotterdam criteria that allows 2 of the 3 of either hyperandrogenism, ovulatory dysfunction, or polycystic ovarian morphology. And then the androgen excess criteria kind of meets in the middle and requires hyperandrogenism, but allows either ovulatory dysfunction or polycystic ovarian morphology. So in 2018 and 2023, there was an international convening to kind of look at these different diagnostic criteria. And this is another view of looking at kind of the difference of PCOS prevalence depending on the population study and the criteria applied. And you can see that even using the same criteria, NIH criteria, which is the most restrictive, the prevalence ranges from 2% to 15%, and then using the less restrictive Rotterdam criteria, the prevalence ranges from 5 to 20%. So really there was an effort with this international convening to kind of take the criteria together and think about what the best way to define criteria might be. So in 2018 and 2023, there was an international convening that supported the Rotterdam diagnostic criteria for adult women, which is the less restrictive of the criteria, allowing for 2 of the 3 of ovulatory dysfunction, hyperandrogenism that could be either clinical or biochemical, or polycystic ovaries. However, I do want to note that in adolescence, ultrasound is not recommended for diagnosis, and we really do focus on only the oligolar anovulation and hyperandrogenism. In the adolescent population, we have less data on overall PCOS prevalence. In a large healthcare system, PCOS prevalence is around 1%. In 2 population-based studies, we had higher prevalence estimates of 3 to 4%. But I just wanted to highlight this because overall, together, population-based samples do lead to higher prevalence estimates based on healthcare samples. And this is something that has been shown in the adult literature as well. In terms of what we know about PCOS pathogenesis, we think that it is a primary abnormality in androgen production that is then exacerbated by adiposity and insulin resistance and hyperinsulinism. What we do know in adolescence comes mostly from studying at-risk populations, and these can either be daughters of mothers with PCOS, girls with premature adrenarche, or girls with that are in the pubertal years with obesity. And this has led to us to kind of put together a potential timeline of PCOS development that begins with some degree of inherited risk, progresses through puberty to begin with some neuroendocrine dysfunction that's potentially exacerbated by hyperinsulinism and exaggerated steroidogenesis. And then in late adolescence, we begin to have the fully developed PCOS phenotype, and diagnosis may occur. in late adolescence or early adulthood. But because we likely have earlier signs that are happening in childhood, we have a missed opportunity for identifying early markers of PCOS risk among the general pediatric population. And kind of simplifying this, this is kind of thought of as the potential vicious cycle of PCOS development, and kind of a classic like chicken or the egg phenomenon, as they're not really sure is any of these a kind of an inciting factor to overall PCOS development, and kind of how do these three factors that we know play a role in PCOS pathophysiology kind of interact together in leading to PCOS development. So my hope with this work was to leverage the Project Viva longitudinal birth cohort to better understand PCOS risk. And kind of for the purposes of this talk, really addressing two key gaps in the evidence, which is one, looking at PCOS prevalence within this cohort, and looking to determine, as I said before, there's a difference between hospital-based samples and population-based samples within this population-based cohort, look at PCOS prevalence, and then look at the longitudinal course of PCOS risk development related to adiposity and cardiometabolic biomarkers. So just a short introduction to Project Viva. So this is a longitudinal prospective pre-birth cohort. Women were enrolled from a large healthcare system outside of Boston at their first prenatal visit, and completed study visits in early and mid-pregnancy. And then there were subsequent follow-up visits from initial delivery all the way through to 18 years of age. And this is a study that is actually currently ongoing now, looking at mothers who are now in menopause and children that are now entering their 20s. So an ongoing wealth of data in terms of the maternal child dyad and health evolution of health over this time. The scope of Project Viva is much larger than my talk today. There have been specifically related to pediatric data coming out of Project Viva, a lot looking at overall just child growth trajectories, environmental exposures, social risk factors, and also understanding early risk for obesity are just some of the studies that have come out of Project Viva. Looking at this kind of study as a whole and the sample for this project, overall there were about 2,000, a little bit over 2,000 live births. About half of those were assigned female at birth. And for purposes of this analysis, we had a total of 417. We were able to assign PCOS status at the mid-adolescent visit. And then a sample of those we had adiposity and biomarkers on. So for the purposes of this study, looking at adolescent PCOS as our outcome, and then cardiometabolic biomarkers and adiposity as our exposures. We define those through both anthropometrics and DEXA measured adiposity for our adiposity measures. And then cardiometabolic biomarkers included glycemic markers, lipids, inflammatory markers, and adipokines, and also androgens. And these were measured at mid-childhood, early adolescence, and then this mid-adolescent visit around 18 years of age. So first I want to dive into how we looked at PCOS prevalence. We kind of, based on some literature previously that had been published within the electronic health record study, categorized both diagnosed PCOS and also probable PCOS, and kind of put those together for a definition of adolescent PCOS. Diagnosed PCOS was based on self-report on this mid-teen questionnaire and a 19-year-old questionnaire in which those that had been assigned female at birth responded whether or not they'd ever been told by a healthcare professional that they had PCOS, or whether or not they were being treated for PCOS by going on a contraceptive. We then defined probable PCOS using the International Consensus Guidelines of Ovulatory Dysfunction, plus either clinical hyperandrogenism or biochemical hyperandrogenism. From a clinical standpoint, that was included as either moderate or severe acne, or using a simplified version of the Ferriman-Galway score. These three areas, chin, upper abdomen, and lower abdomen, were found to be the most valid areas of kind of hirsutism rating that corresponded to the larger modified Ferriman-Galway score. So we use this as our definition of clinical hyperandrogenism. For biochemical hyperandrogenism, we were limited some in terms of what had been collected within this cohort. Free testosterone or total testosterone with the SHBG is the gold standard of hyperandrogenism biochemical measurement. But for this, we had available to us a DHEAS from serum metabolomic profiling. Metabolomics is a way of looking at low molecular weight compounds. And so using untargeted metabolomic profiling within this cohort. They had previously established that there is a relationship between the steroid hormone metabolomic profile and teen adiposity and metabolic health. So we used an internal quartile of 75th or greater, excluding those that were on hormonal contraception, because that can affect your androgen levels. So we had defined greater than the 75th internal quartile as biochemical hyperandrogenism. But I do want to note that this is a limitation, because this does not correspond to how we think about biochemical hyperandrogenism within clinic. So we took those two definitions together to create our definition of adolescent PCOS. Overall, using that definition, we identified a sample prevalence of 13%, and you can see that that was distributed among those that had a self-reported diagnosis. That was a total of 12 individuals. 7 of those are self-reported diagnosis alone, but the other 5 individuals did overlap with the other categories, either being ovulatory dysfunction plus clinical hyperandrogenism and hirsutism, ovulatory dysfunction with severe acne, or those that were ovulatory dysfunction with biochemical hyperandrogenism, and some overlap there. We then went on to compare those that were classified as adolescent PCOS versus those that were not. You can see that there were some social differences in terms of maternal education. There was a lower percentage of mothers that were college graduates among those that had PCOS. There was a higher maternal pre-pregnancy BMI, and as expected, a higher percentage of those had maternal PCOS. We did not identify differences in race and ethnicity between groups, and did not identify a difference in age at menarche between groups. And I wanted to point out here that there were those in the non-PCOS group that did have isolated ovulatory dysfunction, hirsutism, or moderate to severe acne, which also supports prior literature in this area. So now walking through from childhood through adolescence, looking at the differences between those that had later PCOS versus not, and you can see that the first difference that we note is that those that went on to later develop PCOS tend to have a higher BMI Z-score and then a lower adiponectin in mid-childhood, around 8 years of age. When we look in early teen years, around 13 years of age, these individuals were slightly more advanced in puberty. There was a difference amongst all the markers of adiposity that we looked at, both the anthropometrics and also the DEXA measured adiposity. And again, we found some differences in adipokines. In this one, it was corresponding to the greater degree of adiposity, a higher leptin, and then also a lower adiponectin-leptin ratio, which is a marker of overall adipose tissue function and metabolic risk. So so greater adipose tissue dysfunction in those that went on to develop later PCOS versus those that didn't. Moving on to mid to late adolescence, around 18 years of age, we did again find greater adiposity among those that went on to develop PCOS, but what I did want to call attention to here is that about 53% of those that we did classify as PCOS did actually have a BMI that was less than the 85th percentile. And similar to prior findings, there was greater leptin in this group, a lower leptin adiponectin ratio, and then as expected, this was as it's part of the PCOS criteria, there was a greater DHEAS metabolite, although I do want to note that there were no differences in DHEAS metabolites in the younger years here. We then did some multivariate analyses looking at the exposures of adiposity and cardiometabolic biomarkers in terms of the risk of later PCOS. And what I wanted to highlight here is that looking at these markers, that all of the anthropometric and DEXA measured adiposity measures were greater across all of the time points in predicting later PCOS risk, but it does seem that this risk was greatest in terms of adiposity at this early teen time point, and that held when we adjusted for maternal factors in child race and ethnicity. And then in our final model, when we look at biomarker measurement, and child BMI Z-score at that time, can see that we're not looking at the adiposity outcomes here, but you can see that the leptin and adiponectin did still kind of have this trend of being slightly greater at this early teen time point here. So overall here, we found that while in our initial hypothesis had wondered whether or not there'd be differences in earlier glycemic outcomes or androgen levels, it really was the adiposity-related exposures that were most associated with later PCOS risk, even after we adjusted for BMI. So a closer look at adipose tissue dysfunction here, we can see that there was also this risk of adiponectin-leptin ratio even when we adjusted for BMI, stayed strongly associated with later PCOS risk, although this was not present in mid-childhood and early teen, but was only there at that later visit. So summary of results, kind of taking all that together, we found a sample prevalence of 13% of PCOS in mid to late adolescence. This is a higher prevalence than existing adolescent literature, which placed the prevalence more at 2 to 5%. But this could potentially be explained by some variation in our sample. While we did not have overall sample diversity, as 60% of the sample did identify as Caucasian. In our sample, the prior samples had greater than 90% of the respondents identifying as Caucasian, so there was slightly more racial and ethnic diversity in our sample. Our time point of PCOS assessment was later, around age 18, whereas the prior reports of adolescent literature have included those up to beginning at age 15, which is earlier in adolescence, and the full phenotype may not be present. And then also there's the potential that our diagnostic criteria was looser, using an upper quartile for the hyperandrogenism as opposed to a higher prevalence there. But I do want to note that our findings are in alignment with the estimated adult prevalence of about 10 to 13% globally using the Rotterdam criteria. And I also do want to highlight that we did observe PCOS throughout the BMI spectrum, so it was not isolated to only those that had a higher BMI. Those with adolescent PCOS had greater adiposity in mid-childhood, early adolescence, and mid-adolescence, and this is across both anthropometric and DEXA measures of adiposity. And we found alterations in adipokines across time points, but no significant differences in markers of insulin resistance or androgen concentrations. So kind of going back to our question of the chicken or the egg, at least within this analysis, the area that we found that was the first differentiator of later PCOS risk was more related to adiposity. But I do want to have a little asterisk there because I want to kind of note some potential limitations and other directions as we think about this. First limitation being that our measures of insulin resistance and androgen concentrations for this study were not potentially there's a potential for a higher degree of detection using other methods. So we used HOMA-IR, which is a great method for epidemiologic studies looking at insulin resistance. However, it does lack some sensitivity compared to more dynamic measures of insulin sensitivity, such as the kind of the classic gold standard clamp procedure, or even OGTT might provide a better capture of kind of earlier variations in insulin resistance. And for this study, we did not have free testosterone or total testosterone with SHBG. So that is also just a limitation that could have potentially limited our detection of earlier changes for this. And also, as we were going based on previously collected data and did not have full medical records for the participants, there's a potential that a minority of the participants could have been misclassified and have had other reasons for hyperandrogenemia, but at least based on the literature, that was likely a minority, that is not overall a very high percentage of those presenting for care for elevated androgen levels. I also want to note that kind of when we think about PCOS and kind of the note that we did have 50% that were about 50% that had a lower BMI, 50% that had a higher BMI, that we do have growing evidence that when we talk about PCOS, we sometimes think about it as all one diagnosis, but we have growing evidence of the heterogeneity of PCOS. This is sometimes captured in thinking about within the Rotterdam criteria, which is the most general. We have different phenotypes, and those phenotypes can either be the most severe, that kind of mark all three criteria for PCOS, and those that are primarily either metabolic or reproductive. And I'm kind of showing these two pictures back to back because as we usually think about this clinically, there is growing research that does show that kind of when we look at genetic associations and kind of more kind of like metabolic and reproductive outcomes, that there is clustering of different subtypes of PCOS. So we may be kind of using everything under an umbrella, but we are actually kind of talking about multiple different pathologies. So want to kind of have put just like a cautionary asterisk in terms of making any kind of like broader conclusions, although this is compelling about the important role of adiposity in impacting PCOS risk. So future direction within this cohort is really kind of like hoping to use some of this well-characterized cohort to better understand other potential predictors of later PCOS and looking along the way in terms of longitudinal trajectories, even going back to earlier childhood of growth, adiposity, and adipokines, looking at other exposures, whether it's health behaviors or pre and perinatal exposures in terms of determining overall PCOS risk. And with that, I thank everyone, both on my K-23 mentorship team, our Project Viva team, take the Anne Klibanski Award for this opportunity, and many more. And also wanted to thank my pediatric endocrine department as well. So I'll turn it over to Shy now.
Thanks so much, Dr. Wooten. We're going to switch slide decks. And I do understand that much of the Division of Pediatric Endocrine is together on a Zoom, so we have more folks than you can see. Dr. Srinivasan, it's your turn.
Thank you so much for the opportunity to present. It's just really so exciting to be virtually back at MGH to present, and wish I could be there in person. And also a great privilege to present under Dr. Anne Klibanski's visiting lecture series, someone whom I have great respect and admiration for from my time at MGH. Okay, so we're going to shift gears and talk about the genetics of type 2 diabetes in youth, a bird's eye view of where we are and the road ahead. Here are my disclosures. So I'm going to start off by going over the epidemiology and pathophysiology of type 2 diabetes in youth, the current landscape of type 2 diabetes in youth, and just share some thoughts about the future directions for the field of genetics as it relates to pediatric type 2 diabetes. To set the stage for the problem, so type 2 diabetes, as we all know, is unfortunately no longer a disease of just adults. This is data from the Search for Diabetes in Youth study, which was a population-based observational study showing the increase in incidence of type 2 diabetes in youth from the years 2004 to 2012. Further divided by racial and ethnic subgroup. And while you can see that there's an increase in type 2 diabetes incidence across all subgroups shown in purple, the increase is particularly dramatic in youth of color. And so when Search quantified this, the incidence of type 2 diabetes in youth increased by 5% per year between 2002 and 2012. And the prevalence of diabetes, which they also collected, doubled from 2001 to 2017. And again, there was a disproportionate burden on youth of color. And I just wanted to contrast this with their data in youth with type 1 diabetes. So there has been, again, a subtle increase in the incidence of type 1 diabetes, but you can see that it is nowhere as dramatic as for type 2 diabetes. And again, the disproportionate burden you can see the disproportionate burden for the youth of color in type 2 diabetes. The COVID-19 pandemic only made things worse. So this is a study, a multi-center study that we did of 24 sites in the US, showing the new cases of type 2 diabetes recorded before the start of the COVID-19 pandemic, marked in with this black line in February of 2020, with the years since the start of the pandemic. And we showed that new cases of diabetes increased by 77% in 2020, 2021, compared to the mean of the previous 2 years. And the frequency of metabolic compensation, which is shown here in blue, so that would be DKA or hyperosmolar state, also increased since the start of the COVID-19 pandemic. And then future projections indicate that there will be at least a 4-fold increase in our numbers for pediatric type 2 diabetes by the year 2050. So this is an emerging threat for children. And then when we look at disease course, we now know that youth with diabetes have an aggressive disease course with increased mortality. So this is data from an Australian death registry study, which shows mortality rates for individuals with type 2 diabetes, shown in black, diagnosed between the ages of 15 and 30, compared with individuals with type 1 diabetes diagnosed again between the ages of 15 to 30. And we can see here that the cumulative survival is lower for those with type 2 diabetes compared to type 1 diabetes diagnosed at similar ages, with a hazard ratio 2 times for type 2 diabetes compared to type 1 diabetes. And youth have a high risk of early complications. So this is data. We now have long-term data on the risk of microvascular complications for type 2 diabetes diagnosed in youth, thanks to the TODAY study, which is one of the only clinical trials of type 2 diabetes in youth. So the Today study did a long-term follow-up of their participants. And when they reported this data, the mean age of the participants was 26.4 years. So these were all very young adults. And the mean time from diagnosis of diabetes was just over 10 years at 13.3 years. And you can see here the incidence of complications. On the left, you can see the baseline prevalence as well as the cumulative incidence. Very high numbers for hypertension, kidney disease, dyslipidemia, nerve disease. And when they pooled this and looked at any microvascular disease, the cumulative incidence of any microvascular disease, so to the nerves, retina, or kidneys, was 80%. And the same cohort had 6 deaths and 17 cardiovascular events, again, showing how aggressive of a disease youth onset type 2 diabetes is. So there are unique differences between youth and adult onset diabetes. You could ask a question, why study the genetics of type 2 diabetes in youth? There are millions of adults who have type 2 diabetes compared to maybe thousands in kids. And so why is it important to study this in children? And I would say that is a very fair question. But I think there are very unique differences between adults and children who are diagnosed with diabetes that actually serves as reason as to why we should also be studying genetics of diabetes in youth. So diabetes, as we all know, type 2 diabetes is caused by the complex interplay of genetic, environmental, socioeconomic, and cultural influences. And there are many risk factors for diabetes, both in youth and adults. The first and foremost, which is obesity, genetic predisposition, which we'll talk about, race and ethnicity. So being of youth of color, it places you at higher risk for the development of type 2 diabetes. A family history of type 2 diabetes, maternal gestational diabetes, which has now emerged as a very important risk factor for the future development of diabetes in the offspring. Female sex and puberty. So while some of the initial risk factors that I laid out are common to both youth and adults, female sex, the type 2 diabetes seems to be more common in girls compared to boys. And puberty is something that is very unique to type 2 diabetes in youth. So puberty is a state in which in all children, regardless of whether they go on to develop diabetes, they have a transient decrease in insulin sensitivity or increase in insulin resistance, secondary to all the pubertal hormones, including increased growth hormone, as well as the sex hormones. And this is often a tipping point for the development of type 2 diabetes in youth. So when we look at the pathophysiology, we now know that there are differences in the pathophysiology of youth compared to adults. So youth have greater insulin resistance for any degree of adiposity compared to adults. So this shown up top is just to remind everyone of the relationship between insulin sensitivity and insulin release in the normal state compared to impaired glucose tolerance and type 2 diabetes. And so this is data from the RISE study, which compared the insulin resistance as well as insulin beta cell function for both youth and adults who are either at risk for diabetes or had early diabetes. And this is data from their hyperglycemic clamp study. And shown here, you can see that youth have lower insulin sensitivity, or again, greater insulin resistance for any degree of adiposity compared to adults. And then when they looked at insulin secretion, youth had greater insulin secretion for at any level of insulin resistance. You can see that the youth shown in red have a greater degree of insulin secretion. And it is this beta cell hyperresponsiveness that is potentially thought to contribute to the early beta cell burnout in youth compared to adults. And again, which is likely to be contributing to the more aggressive form of the disease. And then another aspect, youth with diabetes come from homes with challenging socioeconomic circumstances. So again, this is data from the Today study. And you can see on the left are the basic demographic features. So on average, these youth were 14 years of age, mostly female. The majority were non-white. But I want you to focus on the right-hand side column, which shows that only 38.7% of these youth lived with both parents, and 9.2% of these youth lived with neither mother nor father. Again, looking at parental education, a large percentage of these youth came from families where their parents had less than a 12th grade education or just some high school education and very low annual income numbers. And while this is data from one single study, we're all, as clinicians, we all see this every day in our that this is very representative of the demographics of youth with type 2 diabetes. And again, while disadvantaged racial and ethnic groups are at high risk for diabetes at all ages, this association seems to be particularly strong in youth. So with that background, moving on to the genetics of type 2 diabetes. So like I said, type 2 diabetes is caused by environmental and behavioral factors that are overlaid on a background of genetic predisposition. And where does this evidence for the heritability of diabetes come from? And I think there are many examples to show that. So the twin studies have shown that concordance for type 2 diabetes is greater for monozygotic versus dizygotic twins. And then the fact that the incidence of diabetes is much higher in certain racial ethnic groups, again, lends evidence to the genetic basis for type 2 diabetes. Family history is an independent risk factor for type 2 diabetes. And then monogenic diabetes, or MODY, in which single gene mutations are sufficient to cause hyperglycemia, again, is another evidence for the heritability of diabetes. So there are now, in adults, there are over 700 genetic variants that have been found to be associated with type 2 diabetes in adults. And the overall heritability is in the 30 to 40% range, with about maybe 50% or half explained by identified variants. However, until recently, the genetic basis of youth onset type 2 diabetes has remained largely unexplored. So to solve this, in 2015, a consortium called the Progress in Diabetes Genetics in Youth, or the Prodigy collaboration, was formed. And this was formed by the collaboration of 3 study groups. So the Today study, which was a clinical trial, and it included the data from 699 participants in the original trial, as well as over 2,000 participants who were part of an ancillary genetic study. Search for Diabetes in Youth, which was an observational cohort with 449 youth with diabetes, as well as T2D Genes, which was an which, as we all know, is an adult diabetes genetic consortium, and at the time had over thousands of both cases and controls for diabetes. And I think it's really amazing that the principal investigators and leaders of these groups had the vision to come together to collaborate and pool these samples and resources so that we could start to study the genetics of type 2 diabetes in youth. So we conducted a GWAS, or genome-wide association study, for type 2 diabetes in youth, and this shows the demographics of the cases and the controls. So in total, we had 3,000 cases, and we compared this with 6,000 adult controls. So these were adults who are greater than the age of 50 without diabetes. We also compared this with a small number of youth control subjects. You can see here on average, these were youth who were about 15 years of age compared to 54.2 for the adults, and similarly aged youth controls. The majority of our youth cases were female, and you can see that doesn't hold true for the adults or the youth controls. Majority, again, non-white, majority. These were all children who were obese, so the BMI Z-score greater than 2, and then you can see that they had elevated fasting glucose, fasting insulin, as well as hemoglobin A1C levels. So through this GWAS, we identified 7 genome-wide significant findings associated with type 2 diabetes in youth. So shown here is the Manhattan plot with the genome-wide significant variants highlighted. The variants that we identified have all been previously been identified to be associated with diabetes in adults, with the exception of a variant in PHF2, which is novel. And so the other variants that we identified were the very well-known type 2 diabetes variant TCF7L2, and other variants such as MC4R, which is a well-known, again, obesity variant, in addition to other variants that have already been identified in adults. In Prodigy, in this study, we also wanted to see if what the aggregate genetic risk burden was in youth compared to adults. So we constructed polygenic scores with, at the time, 303 published adult diabetes variants. And what we did was we compared the odds ratio, the association with diabetes for youth type 2 diabetes cases versus adult controls, adult cases versus adult controls, and then youth cases versus youth controls. And you can see here in all compared to the other two scenarios, the odds ratio for diabetes was highest in the youth cases versus adult controls. And then in Prodigy, so this was all common variant analysis, but in Prodigy, we also have access to whole exome data. So what I think I should have mentioned a couple of slides ago is that all the samples in Prodigy, the pediatric samples, have genome-wide genotyping data as well as exome data. And so this is data, a study that was led by Sean Kwok as well as Jason Flanick. And they looked at both common and rare variant associations. And you can see here the associations for youth onset diabetes, both for common and rare variants, as well as adult onset diabetes for common and rare variants. And these box plots show that they're further divided into tiers of genetic risk. So the lower box plots show are comprised of variants that are most strongly associated with diabetes compared to the ones up top. And they found that the genetic variants explained for diabetes were increased by 3 to 4-fold for common variants and 4 to 5-fold for rare variants in youth versus adults. So when we put all of this together, these results indicate that there's a significant overlap with the genetics of type 2 diabetes in adults, but the aggregate genetic risk burden is definitely higher. In Prodigy, we also looked at the incidence of monogenic diabetes. So as we all know, oftentimes any diabetes that is not antibody positive is classified as type 2 diabetes, but a small percentage of these patients may have monogenic diabetes, which is what we wanted to look at in Prodigy. This is work that was led by Jennifer Todd and Tony Poland, and they looked at whole exome sequence data in 3,333 participants in Prodigy with type 2 diabetes, and they found that 2.8% of these youth carried a likely pathogenic or pathogenic variant in the most common MODY genes, HNF4 alpha, GCK, HNF1 alpha, as well as a small number in PDX1, INS, and SAL. We also found that the MODY youth had a younger age of diagnosis, a lower fasting C-peptide levels, and were less likely to have hypertension and had a greater HDL cholesterol levels. But overall, there weren't a great number of distinguishing factors between the MODY cases and the type 2 diabetes cases, highlighting the importance of us having this in the back of our mind as we see these patients and making sure that we test for MODY. So finally, moving on to what are some next steps for the genetics of diabetes in youth. First, I wanted to highlight two areas where we're making a lot of progress in the area of genetics. And the first thing is in the relation to pharmacogenomics or drug response. So genetic variation may affect drug response. And I'd like to take the example of metformin. So metformin is the first-line therapy and the foundation of all diabetes algorithms. And in particular in youth, I think metformin still remains quite important because it is oral, low cost, and has an extensive safety profile. So metformin response, there is a genetic basis to metformin response with a heritability estimate anywhere between 20 to 34%, which is an estimate comparable to other complex phenotypes. And there have been GWAS or genetic studies in adults that have identified variants associated with metformin response, starting with the initial variant ATM, later SLC2A2, variants PRPF31, CPA6, and STAT3. And then Josephine Lee, Joe Lee, an endocrinologist at MGH, has done work in the diabetes prevention program that have shown that variants in ENOS F1 and OSMR1 are associated with metformin response in the metformin arm of the DPP. So we did a GWAS for metformin response in youth. I'd like to point out that the sample size is quite small. So we had 506 participants with metformin response data, and not surprisingly, largely related to sample size, we did not find any genome-wide significant variants, but we did find that several variants met a suggestive significance threshold, as you can see here. And then in particular, highlighting one variant, RS7619529, which is a variant in ATR-NL1, which is associated with the worst metformin response in adults in the Metformin Genetics Consortium. And then genetics can help disentangle the heterogeneity of type 2 diabetes. So we now know that type 2 diabetes, even though it is one sort of global diagnosis, is definitely a very heterogeneous condition. And this is work that is led by, again, an MGH endocrinologist and geneticist, Miriam Udler, who created cluster-specific partition polygenic scores. So using a soft clustering method, she found that there are groups of genetic variants, also called partition polygenic risk scores, that are related to certain aspects of physiologic function that relate to diabetes biology. So for example, in her original paper, she identified 5 clusters, 2 related to insulin deficiency and 3 related to insulin resistance. And so in Prodigy, we evaluated whether these same clusters that were derived in adults can be used in children, and we were able to validate them in youth. Again, our sample size is around 500, and showing, for example, C-peptide as a trait was associated with the beta cell cluster. What needs to happen as next steps is to now evaluate these cluster polygenic scores with both treatment response as well as with the development of long-term complications work, which is currently ongoing in Prodigy. But a lot of work remains to be done in the field of pediatrics. Definitely, there needs to be functional characterization of the identified variants. We now know more and more the importance of the role of the environment in diabetes risk, and so a study of gene-environment interactions is definitely important. And I think most importantly, we need to have increased sample sizes through collaboration. So a limiting factor for a lot of the pediatric genetics work is the relatively small sample size compared to studies in adults. While it's great that we still don't have such huge numbers of diabetes cases, I think we're still not capturing all of the existing cases. So I think it's important for pediatric diabetes studies to collect samples for genetics and for us all to collaborate to study this more. So to put it all together and summarize, youth onset diabetes is on the rise and disproportionately affects youth of color. Youth with diabetes have an aggressive disease course and an high risk of early complications. There are important pathophysiological differences between youth and adult onset diabetes. Youth with diabetes have a greater aggregate genetic burden for both common and rare genetic variants compared to adults. Some youth with a clinical diagnosis of diabetes may have monogenic diabetes, so important to keep in mind and look out for. And the future of genetics for pediatric diabetes is promising, with more to come in the field of pharmacogenomics, subclassification of youth onset diabetes, and more. And with that, I'd like to thank all of this genetics work has been a huge collaborative process. And so I'm really grateful to have had the opportunity to work with the Progress in Diabetes Genetics or Prodigy Consortium, and a really special thanks to my mentor, Jose Flores, who gave me the opportunity when I was a fellow at MGH, and just one of the most brilliant and generous mentors. Just want to thank the other Prodigy collaborators, Phil Zeitler, Donna Dabalia, Jennifer Todd, my colleague. She and I have been part of the Prodigy Consortium since the beginning. Ling Chen, Elisa Manning, Chema, again, all at MGH. My UCSF mentor, Kathy Giacometti, collaborator Sukwa, And then my current collaborators and mentors, Miriam Adler, who has, continuing to take a lot of this work forward and just has the best ideas. And then Ray, a pediatric endocrine fellow at Boston Children's, who's now actively leading some of the new projects, and I'm grateful to have funding support from the Pediatric Endocrine Society and IDDK. Thank you so much.
I want to thank both Dr. Srinivasan and Dr. Whooten for really tour de force overviews of both of their incredible research. We have a few minutes to open it up to questions. We can do that moderated through the chat, or I always try and encourage people to just unmute and ask your question here. I just want to thank you both for really phenomenal presentations. Our friend Dr. Single, who's like covering both coasts for us here, just unmuted her video. Viva, were you about to ask a question or a comment?
I was. Thank you so much, Shannon. Thank you, Shy, for an amazing presentation and really great body of work. For my own sort of clarification, when you present that there is a differential association with some of the characteristics between youth and adult, how do you sort out the genetic underpinnings of that versus just that physiologically youth are in a greater state of insulin resistance and hence would have all the greater implications? So statistically, how do you sort it out? Like, is there something like mental Hansel's, just to see that the associations are significantly different? And physiologically, how do you tease that out?
Yeah, great to see you, Viva, and I'm glad the West Coast can claim you as ours now. Yeah, that's a great question. I think we're tackling various components of these. I think the answer to your question is there are probably differences across all of these elements. Through the studies that I showed, we're able to show that there's greater aggregate genetic burden. That is one element. I think there are various other elements where there is probably likely also a greater environmental exposure, which is leading to the greater obesity. But I think that is a limitation of what we're doing, is that we're not quantifying any of that, or the past studies have not measured that enough. So I think that at this time we're approaching all of these things independently. And I think that work needs to be done to integrate all of these various risk factors that contribute to diabetes risk. But you're right. I don't think it's this or that. I think it's a combination of all of this. I think the genetic it's all of these environmental exposures overlaid on a background of genetic predisposition. And we're just measuring these now independently.
I don't want to take all the time and monopolize, but just a thought as to, designing preventive studies for the future. If we could, we think I'm just projecting from the obesity world that we're thinking of prevention studies based on genetic risk scores, doing a targeted prevention. Is there anything in the line for type 2 diabetes similarly for youth prevention, right? Like drug trials or something to do targeted prevention based on your studies and others?
Yeah, not specifically in the realm of genetics. I think most of the diabetes prevention work is sort of the work that you're doing in the obesity space, and so I think nothing that I'm aware of in the genetic space. Yeah.
Thank you.
We might have time for one super quick question, and if not, we may wrap up. Any other questions burning on people's minds? Okay, we are just about at the hour, 1 o'clock here on the East Coast. So I just want to thank both of you. That was really just so informative, and I think relevant for many fields, many of which are kind of demonstrated by folks I can see in the audience here, and certainly for all of us who touch young children and young adults. So thank you both so much. That was really just wonderful.
Thank you.
Thanks.
Thanks to everyone who's here too.